Hey, what's up? You can eat. Yeah, sure.
Do you want me to do this here?
I don't give a shit. Doesn't matter to me. Whatever you prefer. You won't bother me.
Yes, I will bother you.
Nope, you're not gonna bother me. So you pick what's good for you. You can share the bed with me too here. I can't see well, but you can probably see better.
Dave, did you get a chance? I sent you an email earlier this morning. I'm not sure if you even got the chance to see that or look that over.
What I did was I just copied and pasted it into like a Word document,
Uh-huh.
and I'm gonna put that right at the front, and then I'll put in. We'll go over after,
Cool. Thank you so much.
kind of when that all. Get you in.
Yesterday's workout is hard.
Oh, come on, that wasn't so bad.
No, that's like 100 wall ball and then 40 burpees. 70 something need to chat. I can feel that in my hamstring just a little bit, not too much.
I can feel it in my hamstring.
Nice.
So we're all doing CrossFit a couple days a week. So I'll do the workout in the morning. Other people I work with will do it in the afternoon. So we're just comparing how our bodies feel.
Yeah, I think that's a standardized reassessment.
Okay, reassessment to see how our body's doing.
I feel like Romeo has the most response for each session. I text Kevin to start like shadowing with coach. So yeah,
Good.
he probably gonna text back.
Yeah, he can be a couple hours right next day. So you don't hear from him. It's not personal. Kind of the way it's flowing. All right, a couple questions we had before we get going. Can we clarify arthrokinematics of the U joint and facet joints? Arthrokinematics, you know, arthrokinematics is it's think of the joint, the glide of the joint. They often talk about the facet, let's say the anterovertebral joint first, as being a guide rail, often for flexion and extension motions. So what happens is I go forward like this, it basically, because you have this U joint configuration that's kind of shaped in this way, this is the inferior joint kind of here, then you have the superior joint here. It's a guide rail. So if I'm going forward, it guides it forward and keeps it in kind of a track. Betting's debated. I've read places and we get Eric's and what Eric has read and where he is on that is I usually check inside betting because it's an inferior medial, glide. You can go inferior medial posterior. It's got an inferior medial anterior vector because of that guiding moment that you get with that flexion extension. They talk about side bending as not being a big motion there, but it does contribute to the side bending. And it's how we check it. Now, I do know that when you find that somebody starts to get arthritic U joints, one of the first things you see as being limited is the side bending component. So classic thing I think of is a 40-something-year-old female tends to feel a little bit tighter earlier than a male. And then the male is usually it's late 40s, 50s. But kind of my expectation when I go in there is that they'll be built with arthrosis and this restriction in that motion. So you'll hear us many times refer to that glide as being on the superior joint and inferior medial. There's the inferior medial posterior, which is the imp, but you can also add an anterior vector to it too. Check an anterior glide of that joint. Sometimes it'll be the anterior component or the posterior component is the one that's restricted. And that's what we'll spend more time with in module 7 is kind of fine-tuning the techniques you've already learned. Different barriering techniques to them. The set joints, other than C1 and C2, C1, C2, we're going to think of being as a flexion and extension glide. Okay. Now that glide and that shape of the joint, if I'm looking at it in side view, they'll often talk about a 45-degree angle. So superior joint, inferior joint, I have this vector like this. The facet joints get longer as we get lower, so you'll have a little bit more stability in them. And as far as rotation, the lengthening of the facet joints and the angle, but roughly that 45-degree angle, that anterior plane, so they're going this way. But if I flex forward, I have the facet joint. Let's say we have 2 on 3, or let's say a 3 on 4 gliding forward in this way into flexion. And again, the U joint then it's going to be more of like could be kind of an anterior, guide to it as well. Teresa, how do you understand the U joints and facet joints? How is this different, or is this kind of what you had in mind?
I guess because like last week, Eric was talking about some joint glides and I didn't get the chance to write it down.
Okay.
And I haven't gone back to see if you uploaded the recording of last week to kind of go through it again myself. But so you're telling me, because what I thought was that when we're talking U joints, we're just talking imp and sal. But you're telling me with an imp, there is some anterior component.
It can be an anterior vector and a posterior. Mostly when we're checking it, we're usually going down and inferior. And a lot of it's going to be the inferior, the slight medial, slight posterior. But we're going to check the anterior and the posterior glides. I remember if I did it during this course, I have to go back and look at notes. I think I mentioned it, but I think we'll spend more time with it in module 7. See, okay, is it the anterior vector or the posterior vector? Because you can do a anterior directed or a posteriorly directed manipulation to the U joint if you find that, hey, it's this U joint, it kind of going down okay, but it doesn't go anterior. This thing feels stiff. Direct my manipulation anterior, posterior to the joint.
Okay, so basically you're saying more to come on this.
Yeah, you're going to practice and refine it over there, but it's just a matter of changing your vector from a posterior vector where if I'm here and I'm coming down to maybe a little bit more of an anterior vector. I'm still going to go inferior there, but I'm going to lift a little bit. Or I can get right on the joint and just take it anterior or posterior.
Right. Did I have that written right? So like when we're talking about right side bending, the left facet is flexing, the right facet is extending.
Yep.
My left U joint is going in that sal direction. My right U joint is going in an imp direction.
Yes, correct.
And then how about for rotation? How are the facets and the U joints in the lower cervical spine?
Start with the right facet joint. I'm going to the right. What is my right facet joint doing?
Going into extension. My left is going into flexion.
Deflection, correct. What is my U joint? Well, think about it coupled this way. What's the side bending that's coupled? It's ipsilateral, right? Or most of the time, ipsilateral.
And so my right U joint would be doing an imp, and my left U joint would be doing a sal. Okay, so it's the same. Okay.
And think of them as being you can't really even isolate them. They're coupled. They're usually coupled motions. So you can think about it. It's usually they're going to be coupled. They don't often happen in isolation. That's why we'll talk about once you start doing this a lot, you realize, oh, I'm manipulating a lot more oncovertebral joints than I am facet joints. I manipulate 2-3 a lot as a facet joint, but I do a lot of oncovertebral joints, even more than facet joints, because they tend to be a little bit more arthrosed by their nature. They tend to be a little bit more limited. And then it skews the axis by which it rotates.
Okay, so what Eric talked about last week that I got confused, was it that actual anterior component of a imp glide that he was talking about? I can't remember what he was talking about last week and why that confused me so much.
Okay, I'd have to go back and look at it.
Okay, I'll wait for you to upload it then and then rewatch it.
I think I put it up Monday, Tuesday. It should be in the email.
I saw your email. I didn't see last week specifically.
I'll go back and double check it then.
Okay, cool. Thank you.
Oh, you know what it is? I may have, okay. I think I may know what happened. Last week's may
not. I don't think last week's is on there.
Okay, thank you. I think what it is I uploaded those to YouTube that Thursday, but I didn't get a chance to process them until like that Monday or Tuesday, and when I sent it out. But when I uploaded to YouTube, that one hadn't downloaded yet, so it was a sequencing thing. But I see where I made the error. I'll try and do that today. I'll have a little time after this. Good. Next one, I believe. So you're getting muddy with flexion direct versus indirect. C3 mobilizations, manipulations. Think about this. I was actually teaching this yesterday. Let's go to 3-4. Okay. So we're gonna do, what do we want to do? We want to do an indirect. Let's do the direct technique first on the right. C3 on C4, facet joint. So I'm going to take the right C3 down into extension, stuck in flexion, won't extend. So I'm going to come onto that with my right hand.
Sorry. Can you start over? What segment?
The
What
right
side?
C3 is stuck in flexion and will not extend. So the right C3 facet joint won't go into that side bending or extension position. So I want to extend that joint. So my direct technique would be placing my right hand on the C3 and manipulating it down directly on the joint. Now my stabilizing hand for that technique is likely going to be on C4 on the other side. So I'm going to block C4 over here, take C3 down on C4. Now, my indirect technique is literally in some ways just changing my manipulating hand. I'm gonna basically, with that one, I want to get C3 on the right to go into extension so I can translate the spine into left translation, which will create an extension moment at the right joint. And now I can take 4, and by manipulating 4 down and swinging 4 down on the left, creating a relative upswing of 4 on the right, while stabilizing 3 on the right, I can do the indirect manipulation technique. My hands did not change position.
Sure, but did you change to favor flexion, or are you still favoring extension up to
Still
that
favoring
point?
extension. I still want to extend C3 on C4 on the right.
Sure, okay.
So that shift from right to left shift will take that right joint into more extension.
Okay.
I'll shift this way, come here, and go down and in. So for me, it's just about, which one is my 80% hand, which one is my 20%.
Mm-hmm.
And it's favorable if that joint is thing. So if I have an irritable joint at 3-4 on the right, then my indirect technique will be favorable because I won't irritate that joint as much. And some people just prefer the indirect technique because they feel like, okay, I can do a little bit more on that. I tend to bias to a direct technique, or just how do I get the end feel that I want. And there's also alternative stabilizing through the cranium, which we talked about a little here, where I can just take the head, I can side bend the head and compress. And that's going to give me stability from above down, and then I can manipulate with an indirect or a direct technique with the cranial stable. I know it all gets muddy right now, but the cool thing about why it's good is the fact that we get these last 2 modules really to work on refining everything. It's not like, bam, you take a course, here's a bunch of techniques, go out into the world. It's going to be that, okay, we can come back and answer those questions. We can refine that piece that's missing. For all of you, for something or half of it, you're missing 10% or 20%, which makes it that aha moment. And your goal is to get to that aha moment in these next couple modules and focus on those things that I'm just missing this piece with this technique. I want to go into this weekend and I want to refine this technique in this moment. Do it. Anyway, hey Anthony, you're Tony. You doing much uncomfortable joint cervical minutes?
Yeah, pretty regularly. My caseload is a lot of in the 50 plus range.
Okay.
So I'm spending most of my time on uncovertebral, a lot of arthrosis, manipulations, a lot of mobilizations too, especially for some pain modulation as well, and just getting into that really stiff, firm capsular end feel as well. But pretty much all directions too. I'll start basic and then definitely get into the weeds of anterior, posterior directions based off of how the motions start to get cleaned up.
Yeah, how much of the uncovertebrals would you say, and you're in the 50s, it sounds like you're probably similar to me, where I'm using these as a lot of mobilization when it's kind of a capsular tightness or it's stiffness in that older person versus an articular friction. Is that a fair statement?
Yeah, I think so. Yeah. and a lot of it's just based off of comfort too. Like they feel really comfortable. Those mobilizations feel really good. They'll tell you like, oh, this feels necessary. Like it's just exactly what they need, and it's very hard to do on their own. And the motion improvements are well sustained, especially when you get them moving right afterwards too.
Do you use the neck rolling technique where you take your hands and kind of roll down the neck?
Oh, absolutely. Yeah. That's
Yeah.
great for the soft tissue. It's a nice way to assess it too. Induces a lot of like relaxation. So I'll do that with like cell and imp directed movements too.
Yes.
It's a nice way to kind of be like fine tune it, get them to relax if they're really guarded. A lot of people are afraid of their neck anyways, just based off of like, things they've heard, media, history, things like that. So it's a nice way to get people to relax. They feel good. And then once I kind of like take note of the segments, I'm like, all right, these are the stickier ones. We're feeling very stiff end feels here. If they're nice and relaxed, nice quick little manipulations, and then follow those up really quick with mobilizations too. Like, all right, we got some movement. We're doing some nerve modulation. Now let's get in the end range and start addressing some of that capsular restriction.
Yeah, and as I roll, like Teresa, what do you think about as I roll down the neck, kind of going this way? Like my first one may be a bit more of an anterior roll. So as I go into my glide, I might put my hand, if I'm on the transverse process, I'll glide my hand to the undersurface of the transverse process, and I'll do my anterior glide. Then as I do my next roll up, I'll come down, and my next roll down I'll come around the transverse process to the anterior portion of it, and I'll do a posteriorly oriented imp. So I'll do an imp. I don't know what the other one is. Is it impa? It's probably impa is the other one. So just by changing my hand on the orientation of the transverse process, I can do the inferior medial posterior by being a little bit more of an anterior tip of it, where I come to the posterior tip of it, and now I can check the anterior glide. I'll roll through, like Tony's talking about, as basically a gross assessment mobilization. People like it. The idea of it feeling necessary is a good way of phrasing it, Anthony or Tony. I mean, it's just a nice way of thinking about it, because that's what they often feel like, loosening it. So whether it's the arthritic patient and it's ankle loose, and I'm not going to get in there and be more aggressive, or that person where, yeah, this is the one joint that's stuck, I can roll right in there. I'll drop this hand and I'll do the manipulation basically right in the middle of it. And then joint moves, and then I move on. So after a while, this can be very clean and efficient. But it's really just practicing these. If you're scared of them, and doing it a bunch of times as mobilizations, it'll work really well. Patients will like it, and you'll develop your feel of these different oncovertebral joints and how your 16-year-old moves differently than your 60-year-old. Teresa, any question for Anthony? Because he's a good one. Tony's really a good one to ask, because he's kind of using it clinically, and you get a different perspective from it.
Yeah, Anthony, who are you?
Oh, he's a mystery man.
Yeah, so fellow in training, been in training, got to get my hours done. So I run the Athletico Muskego Clinic, so up in Wisconsin. I run the spine specialty program too. So a lot of my caseload, spine, neck, back, typically most non-operatively for the most part, but we got some operative cases too. So I got to do some of my fellowship work out with Dave in Baltimore a few years back. So happy to be a resource for any questions and just kind of another perspective as well. Yeah,
he's a great one. Just chat with. His information's out there. Get perspective on how he uses it clinically, what he's doing. He's got a good set of hands and a keen mind on him. And a little note, he brought like he got us these cheese breads after he was here from Wisconsin, and he brought them to a couple of the clinics.
The Kringles. Yeah.
Pringles. Yeah. They both came to me, and then the other one never made it to the other clinic. It got eaten in my car, I think, on one trip home. I'm not proud of it, but I've been to therapy for it now, so now I'm able to talk about it. All right, today, TMJ, I pushed it because I didn't like the way the notes were structured for it. I wanted to get them a little cleaned up for everybody, rather than send everyone into a tailspin 2 weeks before the class. That we may even do afterward, because it may be a lot easier on people. I'll get you some reading before the course. Don't kill yourself over it, but we'll get time to read the course, and then that may be better suited to do TMJ, I think, afterward. I think cramming it into the front of it would have just been incredibly painful for everybody who's probably not really treating TMJ. So as I looked at it, I really thought, okay, this is just too much to jam in real quick. But getting these cases down and clinical reasoning here, it never gets old, because this is essentially one of the old practicals I'd use. Everything, hey, I'm really worried about oral practical. What would I do? is what I've used in module 8, and this is what I've used in oral practicals in the past. So it's a great one to go through and think about. Okay, 51-year-old female, cervical pain, restriction with right rotation. Patrick, what could be restricting right rotation?
It could be a extension or a flexion biomechanically, depending on what side. Could be an extension facet on the right side or a flexion facet on the left side.
Good. About onco, we just talked about onco, and you don't have to be completely correct, but if you're thinking about oncovertebral joint restriction, what would it be?
Yeah. If it was an oncovertebral, you'd expect that it could not, maybe on the right side, it couldn't go posteriorly.
The right could be posterior glide, or even think about the couple like the input glide. So we're going to give and we'll pick a random level here. Let's say this is happening at 2-3. New joint. All right, can't go rotation. Okay, Ariel, above it. What's the first joint that's going to kind of give us motion here? If I'm going into right rotation, thinking top down, what else do we have? We have a facet joint, and onco we're talking here. We said C3, C4. What above it? Pick a joint.
2-3.
Pick a different joint, because that's going to respond very similarly to 3-4.
C1, C2.
There you go. What's C1, C2 going to do?
It's going to, in right rotation, it will, you're gonna get the posterior glide extension on the right.
Mm-hmm. What's the left one going to do?
Anterior medial flexion.
I think downslope too. As you do that,
Right.
so keep in your mind, just think you haven't put it in there, but in the back of your mind, you hear that. Think of down the posterior slope and anterior slope. Because if you add in the slope vector in your assessment, your assessments will feel cleaner and you'll get a better end feel. Very much like when we felt the lumbar spine. Remember, a couple times we've done the lumbar spine. We add the vector, the plane of the L5, S1 facet joint, the L4, L5 facet joint. You get a cleaner end feel. It feels less nebulous. The same is really, really true when we think about the up glide and the down glide of where we are in the vector of C1, C2. So you don't always have to say it, but we can always think of, just the slopes as we do it. So again, posterior down is right down slope, posterior, left would be inferior. Having that slope in there just kind of helps that idea, that vector that we want to assess. Good. All right. Abby, let's go lower. What's the next lower segment we could have that can restrict, other than the mid-cervical, restrict right rotation?
What? So it's mid-cervical right rotation that's limited?
Mid-cervical, we're gonna count C3, C4 as covering kind of what we're gonna see in the mid-cervical, because the joint biomechanics will be the same between the U joint.
So would you go 4-5?
Now I want you to go lower. Thoracic. You have thoracic. You have
Sure,
AC.
let's go
You have
thoracic.
SC.
Oh, I see where we're at now. We've lost. Okay. We can do upper thoracic.
Good. What do we see? What are we gonna see at upper thoracic? What would restrict right rotation?
Well, when you at the end range of right rotation, shoot.
Right
Is it your, I
rotation.
mean, your thoracic spine has to finish that
Yes, thank you.
rotation. So
Great. Buy in time,
wait.
Abby. Killing time here.
Oh my
You
gosh,
can
I'm
do it,
trying
girl.
to think through
You can
this.
take your neck and
So-
rotate it to the right. Turn it to the right. Tell me what happens.
I mean, it's all the kind of the same mechanics. Like the right side extends and the left
Holy
side
cow.
flexes.
Yeah. It's funny. It's always easier than it seems, isn't it? Once you kind of pause a minute. Right facet extension. Okay. Left. Okay, great. Now the good news is we have more stuff here. Okay, what is happening at the costotransverse joint?
Are you asking me?
Yeah, I'm still in you, Abby.
Okay. The costotransverse joint. Oh, it's anterior medial on the right and posterior lateral on the left. Hold on, no, that doesn't feel right. That's it opposite.
The ribs is always kind of moving like the innominate. So when I rotate, the ribs are kind of going this way now. It may change differently as we get the glides because the glides are a little different than the rib motion. So as I go this way, what do the ribs have to do?
They go posterior lateral on the right and anterior medial on the left.
Yeah. It can be confusing sometimes. It really depends on describing the osteokinematic motion or the arthrokinematic motion. So it's the glide at the facet joint. Tony, how do you think about the glides here? Or have you not thought about them in a while?
For which segment or which area? You said thoracic?
Think of like, yeah, we're looking at right rotation. We're thinking about the rib glide. And I go to the right. How do you interpret it? How do you remember the rib glides being? If you don't, that's fine.
Yeah, so I think about them a lot, especially for the upper ribs. So with right rotation, I'm looking at anterior medial glide and posterior lateral on the opposite side. So ipsilateral, anterior medial, contralateral, posterior lateral. And I typically look at that for like ribs 1 and 2. And then essentially, yeah, I would say that maintains for the rest of the range. But for cervical rotation, I'm definitely focused on the first and second ribs specifically.
Yeah. So cervical rotation is first.
Hold on. Can you repeat that? Because I think that was opposite of what I said.
Yeah.
Now, again, correct me if I'm wrong, but when I look at right rotation for right rib, first, second rib, I'm thinking anterior medial glide, posterior lateral on contralateral side.
That's what I said originally, and then I changed it because Dave made me change it.
Did I make you change it?
Yeah, you did.
Which way is the rib going?
Dave just
going
messing
this way.
things up.
You have it typed how I said, Dave.
I was trusting you for a second as I'm thinking about it.
Whatever.
Mm-hmm.
So, Dave, don't trust us. Tell us what we need to know.
This way.
Please.
The ribs, as I do this, think about the same. I'm going to extend on the right. So sometimes it's nebulous because you have the ribs moving, but then you also have the transverse process moving in it. And that's kind of where you can get a bit it gets a little bit funny here because one will stop before the other. I'm trying to remember which one right now stops prior to the other. But I get this way, the ribs have to do this to go with the translation. I think on one, here's the rib rotation here. And where I always see it as, I think what it is, I go, and this is going posterior lateral on the right, anterior medial on the left. So I would see it going this way, but I will confirm it because, again, I've been doing this a long time. And after a while, what I tend to do is I tend to go with the feel and the rotation of the rib versus the osteokinematic glide. So that's the way I interpret it. The way I had it before. That's why I went with it. But it doesn't mean that I'm correct. I will get you a ruling. But the way I see it, as this has to happen, I think of the ring as having to move with the translation. So when I have this ring and I rotate to the right, what has to happen is that I got extension of the facet on the right. I get relative flexion of the facet on the left. The ribs have to travel with the translation. So as I get the vertebral body at that point translating from right to left, the rib is going to get drug along with it. So as I get that motion, you can make the argument that as that happens, is that, I'll look at it again. Left anterior medial, right posterior lateral is how I'd see it going. But I will confirm that because I think it's going to be pulled that way. And as I go this way with this, I see the rib going that way and going anterior, follows along the innominate is how I see it. So I will clean that language up and write that out just to make sure that we're talking the same language. You're gonna get confused too, because sometimes depending on if you're referring to the rib versus the facet joint motion, the language is flipped in what we'd see. But what I want to see with this is I look at the thoracic segment. I tend to think in terms of ring. I tend to think as I get that way, I need extension on the right, flexion on the left. I have left translation. So if my left translation is lost, it's going to beat it up. And the ribs need to be able to create that shrink shift as well. So what I should feel when I'm palpating the transverse process on the right and the rib on the right, as I should feel them separate. In that case, on the right, that would tell me over there. So in that case, in the right, it would be a posterior. That's why I'm labeling a posterior lateral glide. That would feel like a posterior lateral glide to me. If I'm feeling the glide on the left, what I'm going to feel the glide on the left is that the transverse process in the rib, we're going to go this way. They're going to approximate, and that's going to be anterior medial. But that's how I define it, and that's how I think about it when I see it. But I may be describing the osteokinematic motion, not the arthrokinematic. But that's
to clarify, I was pushing arthrokinematic, so
Yeah.
I can absolutely see that. And that's the way my head works. I will echo that when I'm looking at these things, I also focus more on the entire ring, at least initially, before I start breaking it down rib on segment. I look at the whole ring motion. And if I'm going to treat it, sometimes I just start with what the ring needs to do. So I'll facilitate movement into the lateral glide that needs to happen, reassess. And if that's cleared it up, perfect. If I still need to fine tune, okay, then I'll dive deeper into the weeds of rib specific glide, left versus right, and kind of break it down from there.
Yeah, because your technique for this is going to be basically, I rib this high, I do the downward traction technique where I reach across the body. I mean, you could use the snooker or the supine technique, from above. I find that for me to be less effective. So I was going to treat this rib. How would you do it usually, Tony?
So Gail and Fred taught me a way to get the patient in sideline, support the head, and you can bias rotation into the direction you want. And then I get essentially first, or I guess second, MCP, near spinous process. And then I facilitate the glide. So kind of essentially mobilizing straight into the table. Yeah. So I can do like a little just pure mobilization to end range. I can tie it in with mobilization with movement if I want to bias with my superior hand and how I'm supporting the head and neck. It's super comfortable, clears up a lot too. And honestly, if I do that, a lot of times I'm not spending too much time on the rib itself. If I can just get that whole ring moving, clear everything up, a lot of times I think you're almost doing like two birds, one stone, honestly, just by getting that whole ring going. You'll get rib movement, you'll get that lateral translation going as well.
Yeah, because usually it's always think in terms of when you find the rib, treat the thoracic spine first, and then see what the rib is doing. So I'll admit many times I'm lazy. I'll do the rib because it's fast and easy. Then I'll get into the thoracic segment when the thoracic fields are moving. But the thoracic segment, the general rule should be thoracic segment will be a stronger driver of restriction in this individual. But then the rib can also be it too. So that idea of being able to work through it. So when I look at this thoracic region, I know that I have a translation technique I can use. He described a sideline one. We've looked at it from a traction standpoint for that segment. I believe what Eric probably gave you had seated traction. I think he showed you the one with the knee. And we also did basically supine with knuckle and thenar eminence at the same level. I don't know if Eric's teaching. He taught the sideline one. I know I did.
It's worth learning. It's great once you get good at it.
Okay, I'll mention it for module 7. And then All right. Ryan, what else do we have here? How about the SCAC joint? To finish right rotation, which role would you feel in the right AC joint? Your answers are anterior or posterior.
For the right AC, it would be posterior.
Mm-hmm. Yeah, it's going to go posterior. So if you have a restricted right AC joint posterior glide, what would be the most likely cause of that? The most likely cause. It's a trick question, by the way.
That is a good question. So the right AC won't go posterior.
It's the most likely thing that would lock this up. That is probably not the SC or AC joint because it's a trick question.
Could it be on the first rib?
Yeah, you look at first, second rib, or ring lesion would probably be the most likely thing I would think about. So if I see that this thing can't glide back, I'm looking at that first, I'm thinking, okay, let me go back. If I haven't looked at the upper CT junction yet, I go and look at the upper CT junction. Clear that again. Okay, that didn't clear it. So, or that was moving fine. What would be your next thought? Now you're thinking
Is it still with the right AC?
Your right AC joint. Not much motion at the AC joint here.
Yeah, could it be something with the lower cervical, like C7, T1?
You could, but let's say not cervical. What would be the most likely thing that could be restricted here? I would then look at SC joint.
Okay.
Look at SC joint mobility. Do I have anything in the SC joint that may explain this? I'd also look at AC joint as well. But do I have anything in there that would explain it? Now, conversely, you're right. Movement of the upper cervical spine. Let's say I don't see the motion. What's going to happen is, let's say I have a lower cervical issue, and then I go into rotation. I'm side bending my head to not go into my lower cervical spine. Then what's going to happen is that motion will never come down into the clavicle. The motion's getting locked up above it. So if I have somebody who's doing this, I don't expect that clavicle to roll because they're side bending away from it. They need to get pure rotation. And once I get into here, right about here is where I'll get that ring rotation, and the clavicle should get pulled along with the thoracic segments. But if I do that, I'm not going to go down into that lower segment. So as you said, Ryan, that would be a thoracic cause of this. Or it's the ability to spin. And they often talk about that spin or that rotation happening at the SC joint. That's why I would go and then look at the SC joint to see what I need to do. Okay, let's say it is the SC joint, because we already talked about the thoracic spine. What would you do to treat the SC joint? What would be your treatment, Ryan?
Could you mobilize, so like do a maybe like an inferior glide of the clavicle on the sternum?
Are you guessing right now?
A little bit.
Okay. Traction is where you want to go, probably. Like
Okay.
crossbody tract, the kind of the go-to technique. Anthony, do you do anything differently for the SC joint? Still here. No. Tony, do anything for the SC joint?
For SC joint, normally I focus distraction just to, again, so if we're looking at like, if we're still focused on right rotation, I'm thinking right could probably be pretty restricted. I don't play too much with pure direction, but I really like a pure distraction. It really helps, especially like if we're thinking like anterior shoulder rounding and things like that, contributing, especially if you're like, all right, I've kind of tried to clear up thoracic, first ring, lateral glides, and we're still just having some difficulty, I'll get either them supine to do a distraction, or I'll just get behind them seated, stabilize opposite side, get a nice good key grip on right near SC joint, and just kind of got a good pull of distraction with my arm directed into the directional pull that I want to get. It's a little fatiguing, but you can hold it for like a good 30, 60 seconds. It doesn't take a ton, but it's a nice way to kind of open up and loosen up, especially if like clinically you spend a lot of time like, oh, let's dig out pec and stretch pec, and that hasn't really got them anywhere. You can clear up that SC joint. That could be super helpful. And then obviously you can even start tying this into some cervical and shoulder related pathologies too, and how they can influence each other. That SC joint can be a big contributor to that.
Yeah, I do a lot of, it's one of the things I look at early is just kind of the scapular and clavicle mechanics, and just kind of controlling that in that, especially in the later ranges of motion, just that posterior roll. And making sure, okay, if I improve the posterior roll and end range mechanics, it oftentimes better seats the glenoid and reduces the impingement. Then I have to get into some of the muscular synergies that may also be involved in that and how they repattern. But yeah, I'll put a lot of emphasis on just looking at the clavicle and do I get that rotation and spin and treat it. So that's what's nice about this, you're right, because it's like I use the same kind of model when I'm looking at the shoulder as I do when I'm looking at this end range cervical rotation and what we're doing.
Dave, maybe I'm alone here, but I don't remember an SC distraction technique.
Okay. Does
anyone else remember that? Am
Here we
I
go.
blanking, or
it's
you're not
basically we
alone?
did one cross body where for the SC joint, it's pretty simple. That's why I don't remember. It's basically taking the hand, and basically this is my right shoulder. I'm on the left side of the body. I can take my hand with basically my hypothenar eminence, and all I have to do is a pulsing traction down the length of the clavicle. They generally find it uncomfortable, and they tend not to like it. And what Tony, I believe, was talking about, he's doing the same thing in seated. And we'll just confirm with him where I'm seated right now. I'll do the same thing. I'll come across the body and seated with my left hand like this, come onto the clavicle, and I'll do a pulsing mobilization this way. And then as they go up again, or they rotate, as they rotate, I will then take the clavicle and do the posterior rotation or glide here. Or I will get on the thoracic spine and take the thoracic segments there. If I think it's the thoracic segments, I will guide the thoracic segments into left translation, right rotation, or clavicle into posterior roll after I do the traction mobilization coming across the body, hypothenar eminence. Is that kind of what you were doing, Tony?
Yeah, more or less. And Dave, if you find it worthwhile, I'm happy to like do some video of this too, in case you want some like just different technique. I can always throw it in, or just different options. But yeah, it's essentially from a seated position, I can get a nice good grip. It's comfortable, and it's pretty efficient too. It doesn't take much to get that movement.
Dave, it's nowhere in our M6 module that I can find. So
I will get it to you.
That would be nice. Thanks.
Yeah, I don't know how I missed that. It's one that's handy to do. It's not super complicated, but it's a good one to have in there if you feel like, okay, I think this is restricted. But you need it. It's good to have, but it's not like the missing link in your world that pulls everything together either. So, but I will get it in there and kick it out to you in those pages.
So Dave, when you're doing that oscillation,
Yeah.
Obviously you're reaching around their body.
Yes.
Are you trying to stabilize their left shoulder, like with right hand, and kind of oscillating away, or is it?
I can stabilize the manubrium. I can just kind of go ahead and do it. It tends to be a very non-specific technique. So, with this one, you don't have to have quite the degree of specificity. Sometimes what I'll do is I'll take my thumb, I'll place my thumb on the manubrium, and I can traction, and I can come across. You can grab the opposite clavicle, or many times, because the thorax is already on the bed, coming across and doing it in supine will be fine. Imagine when Tony's coming across the body. When you're coming across the body, what you're not allowing them to do is rotate the body as you do it. You're going to hold the body and stabilize the body in the position and just pull a gentle distraction.
Gotcha.
So like within there, Anthony, anything, or Tony, I'm sorry, I keep on Anthony because it's written here on the screen. Right rotation. Anything else in here? What would we look at for right rotation?
So I see we got C1, 2 already down. That's where I would spend a lot of it. So much rotation occurs from there.
Yes.
CT, definitely lateral glides. I'll spend a lot of time CT, and then I would get, so I mean, if I'm gonna order, and I know some of this probably would mention, upper cervical, I would look at CT, then I would get to mid cervical, upper thoracic, and then probably AC is the final. From there, I mean, I guess we haven't gotten to it too much, but potentially muscle tone as well. If we're doing our mobilizations, manipulations, okay, let's look at tone as well, and how the joint restrictions, you can potentially get a facilitated segments. Okay, so I've mobilized, manipulated. What else can I do to ramp down tone? So we're thinking later scap, upper trap. If we're getting to SC, all right, do we got to think about what PEC is doing from what CT junction has done to it? And all right, and maybe we're getting the arthrokinematics, osteokinematics better, but if we're still seeing some like active restrictions when the patient tries to move, then spend some time on tone, maybe some neuromuscular reeducation to help reinforce that as well.
Yeah, when you bring up a point of toning and then scapular position. So, okay, yeah, what would a tight like pec minor? So we have a facilitated pec minor. It's going to pull the clavicle up and forward here. So I'll be in this position. As I get in there with my right shoulders forward, I'm going to get a tighter end feel in my right rotation. Scapula back and down, I'm going to free up probably about 10 degrees. So you're right, if you have a facilitated or hypertonicity, it's going to create an anterior vector and create a pull to that direction of the scapula. Because as I get into this end range here, I get a posterior roll of the clavicle. Again, you can't really separate that sometimes with the clavicle. If I do that to end range, my scapula should have a back and down vector. So as I get in here, because it kind of frees it up as I get that rotation. So the thorax is going to contribute. So if my thorax gets locked up in any way, in pec minor would do it that way. What else would bring it forward? Facilitated serratus anterior. So if I shorten serratus anterior, or a, what would you call it? A protracted scapula would do it for right rotation. Think about upper trap, Tony. You know, you can have lengthening of upper trap. If my scapula is dumped, I'm gonna have lengthening of my upper trap. You know, how would that influence right rotation? Would I expect a lengthened upper trap on the right hand side to restrict that motion? I guess it could, because of the up ramping of levator scapulae. So kind of thinking muscular vectors to get into here, you know, I would think that being able to do this, a tight upper trap would probably go along with it. But if I have my scapula dumped, rotated down, I'm going to have inhibition or lengthening of my upper trap, which is often accompanied by facilitation and overactivation of levator scapulae. What motion would overactivation of my levator scapulae, what influence would that have on the thoracic spine? Kevin, what would the overactive levator scapulae on that right hand side that is taking my scapula, inferiorly tilting it, and drawing it upward, what would be the influence on the thoracic spine with right rotation? Would it restrict it? Would it potentially not do anything to it?
I think if you're restricted it, levator scap attaches a transverse process. So if you're, we'll say, short or tight,
Correct.
I don't feel like that would limit right rotation. Now it would probably limit left rotation.
Yes.
Based on that muscular attachment.
Correct.
Unless you're thinking something else.
Nope.
But that's mid cervical, I guess.
Because it's vector, it's attaching all the way up to C1. So if it's facilitated, attaching like what, C1 through C4, doing that, it's going to be a vector that way. So what I might end up seeing with that is that person who, if they do that, do they tend to extend a bit as they do it? I don't know, Tony, do you look at this much?
For tone, yeah, absolutely. Especially if I've been spending a lot of time with upper cervical 2-3, definitely spending some time on it, because if C2-3's been jammed up, likely the levator is going to be rock hard, and they've likely done self stretchings, gotten them nowhere. Previous PTs that looked at it, they've needled levator scap, they've done manual release, temporary. So definitely reinforcing it after I clean up kind of the arthro and osteokinematics.
Dave, the other thing I would look at is just CT junction. If we hadn't cleared that already, if I see a lot of levator tone, I'm looking at kind of CT junction mechanics.
Yeah.
Which could be limited either direction there, right or left.
Yeah. That's what Fred would say is it's, you're looking at, C2, T2 as the interplay when you see these levator scapulae issues. Is that you usually have something dysfunctional like 2-3, you usually have something going on at the CT junction. So when I'm seeing facilitated levator scapulae, dumped scapula because of the inhibition and lengthening of upper trap, you start to think of you're going to have some type of dysfunction at those two levels. May not necessarily at that point restrict that right rotation. If anything, you might think that a facilitated left upper trap or the facilitated left levator scapulae may have more of a role of creating a muscular restriction in right rotation from the vector that it attaches. How about muscular thread you went into here? And what would be the influence of levator scapulae? Okay, I've somebody's cervical neck pain. So we know, okay, chronic cervical neck pain, okay, classic patterns, you're gonna have up ramp facilitated sternocleidomastoid. Which sternocleidomastoid, if it was hypertonic, would more greatly impact right rotation?
Right SCM.
Yeah. And why is that, Kevin?
I think of the opposite. The right SCM is going to be a right side bender, left rotator. It's also an upper cervical extender. So yeah, if that's restricted, I'm going to be limited in right side bending, right rotation, as well as upper cervical. And we'll see OA flexion basically will be limited most likely if I'm restricted on the right.
Yeah, it's going to kind of pull it back that way. You're going to be kind of in that position there. So right OA, yeah, flexion would be limited. Yeah. So you can think about that. It's like, okay, if I have this facilitation, the hypertonic tonicity in there. So if you're doing release, if you're looking at needling, but let's say, okay, we have no needling, we're not doing that. So, facilitation, this muscle could be in reaction to the pain response, where the global muscles are more active, the local muscles are more inhibited or changed. I could have dysfunction at the first rib or clavicle would facilitate sternocleidomastoid. Again, anything up in the upper craniovertebral region, an irritation there that makes me more comfortable being in this right rotated position could facilitate it. So yeah, we can look at something that's facilitating that, and if we're looking from a muscular standpoint, but we have to play it back and forth. Is my muscle my primary dysfunction, or do I have an articular dysfunction that's driving it? Tony just talked about that, like with levator scapulae, thinking it much like the sternocleidomastoid, that if I clear the articular restriction, I probably have a much better chance of down ramping this long lever tone from a levator scapulae or a sternocleidomastoid. And it's kind of also what they see in the manipulative studies, that when you do cervical manipulation or upper craniovertebral manipulation, you see improved longus colli, longus capitis function, albeit temporarily. But you also see down ramping of the facilitation of sternocleidomastoid. But that's kind of where that idea that then need to follow up with the neuromuscular re-ed, TheraX, movement pattern retraining to basically now get this to be sticky and change that cortical or aberrant pattern that they've developed so that you have some stickiness to it, or else there can be many times that regression to the familiar and they fall back into their pattern. any other muscle patterns in people that you guys come across, thought about or seen that you'd like to kind of throw out there and we can chat about. And I promise I won't grill you.
Tight scalings on the same side. It tends to come with SCM stuff.
Mm-hmm.
And it, affecting rib mechanics of 1 and 2, likely.
Yes. There you're looking at rib mechanics. Are the ribs, do I have a restriction at CT junction that's going to drive this? Do I have something going on at my mid-cervical spine? Do I need, like with these individuals, the oncovertebral rolling that Tony talked about earlier going through, I'm going to do that almost first and see what happens to my scalings. If I restore mobility or I get that proprioceptive input through the spine, do I get down ramping of the scalene tone? It's a nice easy way before I have to get in and do something to the scalene. So I want to see, can I clear it through clearing that mobility? Some of it may be just inhibition because of the proprioceptive input through the neck, but getting the neck moving better and seeing that. At that point, you also, because it's a secondary respiratory muscle, it's probably gonna look down, look at diaphragmatic breathing, and at some point just getting a sense of, okay, do I see anything in their breathing pattern which may be altered that may need to be cleaned up as well? So CT junction, attachment spots to the transverse process, how that influences in the motion at those cervical segments needs to be cleaned up. And then as well as, further away vectors would be diaphragm, thorax, and if you really want to get far into it, you down into pelvic floor.
I'll look at thoracolumbar junction too if they're having problems with breathing. We'll spend a good amount of time there, make sure they're got good expansion of the ribs lower there, you got good rotation. Especially with like you're thinking more just like not just pure cervical rotation, but like athletic rotation. Not do we just want it up in the cervical spine, but we need lower thorax, TL junction moving too. And then we're tied in with like accessory breathing pattern. I will spend a lot of time at TL junction, maybe not day one on a neck pain patient, but as we're cleaning things up or if things keep stiffening up and it's like, all right, I'm mobilizing, we're doing some neuro rehab or progressing some things here. Why does this keep locking up? I will absolutely come to TL junction sooner rather than later.
Yeah, and that's kind of like, again, there's lower rotational patterns. That's the perfect one because really thorax as a total will contribute, but you'll get so much more from the TL junction that you'll get that influence. That's a really good point to bring up in here. And as these rotary segments kind of communicate with each other and do this, I mean, eventually it's going to, if you have 2 hours, you could literally take this patient down into the foot. And I'll do this a lot because I see rotary sport athletes and adults. So many times what I'm doing when I'm cleaning up shoulder and neck problems, I'm down into the lower extremity and how they load and how their substance, how it beats up on the neck. There's a next patient right now that has his cervical radiculopathy. It's kind of coming together, and I was talking with him yesterday about what he needs to do with his footwork to decrease the rotary moment in his neck, but then also to decrease the extension moment in his serve. And to fix his neck with his serve is a drop on the leg. So if he goes, let's say he's right-handed, he needs to flex through his right knee, hip, and thorax to unload his cervical spine in his serve. So if he does that, then he has no pain. So it's really going back to good body mechanics, what's lower and how forces drive through the body. That's what's fun about these next 2 modules too. A good bit of these kind of regional influences. Now that we kind of have all the mechanics. Whew, okay. That was a full day. Tony, that was awesome, man. Where you been?
All over, man. Nonstop. We finally got a second provider in my clinic so I can start to breathe a little bit.
Oh, good. Second provider? Holy cow.
Yeah, second. Yeah, I know.
Yeah, that's hard. All right, cool. No, that was well done. Again, this is getting cleaner. And this is the base package. So this is left rotation. And then layering on those other thoughts of the muscular system and there's other influences. It's good stuff. It's like you guys are getting there. You guys are doing really well with this. So I know it probably doesn't feel like it.
Last 2 modules really bring it all together. It'll start making more sense.
Yeah, you probably go and talk about that, Tony. You got a minute left here. Just tell them the difference over these next 2 modules.
Yeah, so I mean, with like the first 6, it's so like we're focusing on different regions and we're just trying to get the make sense of the biomechanics, osteokinematically and arthrokinematically there. The last 2 bring it in all together, really tied in. And then we really start to recognize the pattern recognitions of like, oh, just based off of the patient's telling me, I know 5 things I'm already going to look at based off of this pattern, based off their history, based off of just even just basic range of motion assessment. Okay, I know I'm going to look at these things. And then as that gets efficient, your treatment gets efficient. You know exactly what to mobilize, manipulate, reinforce with education. And then that really starts laying out the foundation of what their whole plan of care is going to look like. Because if you start cleaning things up, and again, this is kind of the concern with people who get into this program is, oh, am I going to do too much manual therapy? It's like, no, you'll start recognizing this stuff so quick. Your manual therapy will be the first couple weeks, and then the last of it is where you can get to the really fun, highly specific stuff. So if you're working with the athlete, hopefully you cleaned up a lot of stuff. Now you're getting to just more of the deeper training of the biomechanics, getting to the higher level functional training, getting them tired in clinic, doing a lot of the cool stuff just by cleaning all the stuff up early and catching stuff that you would have otherwise missed. I can't tell you how many patients I've had when I was sitting in these courses and be like, oh man, that was this patient. No wonder why that kept happening. No wonder why their hip kept locking up or their shoulder kept getting problems. And I just missed that. I didn't look at this. And you start picking up these things a lot earlier and you just get way more efficient with your treatments. And then you start becoming like the go-to to like, hey, can you check this out? Like, this isn't making sense. I've done this. They've done the standards. You're going to be the 3rd or 4th PT you've seen. You're going to be the first one to finally like actually pick something up and actually take a deep assessment and figure out some of the more underlying problems.
Yeah, it's good. It's good to hear that just going the 7, because it does change a good bit after the next 2. Okay. Yeah, good job today. All right. All right, Tony. See you next week.
Yeah, I'll be here. I got it on my schedule.
Good. That was great fun. Take care.
Yep. You zip. Good to see you. Bye.